acidity or potential acidity with lactated ringers?
It's 6.5 instead of like the, what, 5?
It's less acidic than saline because lactate is a buffer. So if you said,
But there is an acidity issue, right, which is why we don't give it to patients with metabolic acidosis, is that?
we shouldn't give it to patients with metabolic acidosis unless the benefits outweigh the risk.
Is
Meaning
that the lactate, the acidity, is that, am I
lactate
drawing
is,
a connection?
let me say this,
Or the wrong
you have a person that's in cardiac arrest. What is their state, their pH state? Acidotic or alkalotic? Acidotic,
Oh, yeah.
right?
Okay.
If you hold your breath, your acid is
Yeah.
building up, right? Your CO2 is building up.
Okay.
Okay, would you be surprised to learn that one of the most important interventions we can give to people in cardiac arrest is fluid? And you might say, well, wait a second, it's acidic though. And I say, well, if I had lactated ringers, I'd give that instead because it's less acidic, but it's less that I care at this point about the acidity and I care more about the volume, right? And so my point isn't that saline is so bad, it's just that it's the best bad alternative we have because I need volume replacement.
Right.
And lactate is less acidic, so we'll that. Again, I'm almost sure it is merely a storage and follow the money, right? That's my suspicion. All right, you ready for like a 500,000 blast slides? Again, I'm gonna move quickly through this stuff. If you're like, whoa, what the hell was that word? Read your book, look at the slides, do those things. Or again, much as I told somebody's mom recently, like your time is, no, my time is your time. I'm happy to hang out over lunch, after class. I work Monday through Sunday usually. Reach out to me if you need extra help. Where that time ends is largely once the class has passed, because then my time belongs to the next class, which I'm very devout in. So anyways, if any of this stuff you're like, whoa, start by reading the book. If you don't get it, and referencing the slides, call a buddy, do some studying, go through this stuff. And if that doesn't work, email me and I'm happy to clarify any of this kind of stuff. Our respiratory situation is much like many other situations in our body where we have both ventilation and respiration, one being chemical and one being mechanical. Now, I had intended on like hitting some highlights here through these anatomy things. We really don't have time now. So I recommend after I upload these things and you reading the chapter, this is chapter 11 primarily, that you go through this and just hunt for stuff where you're like, wait a second, negative pressure? I thought it was positive. Do some reading. I'm gonna ask questions about that, but we're not gonna talk about it here. Exhaling, what? Is it, when would it take active effort? Why might we have to actively involve ourselves in exhalation, whereas right now we're just doing it without thinking? Say fluid in the lungs, is that what you said? Very good, sure. Any type of dyspneic issue or really ventilatory or respiratory disruption, whatever that is, respiratory disruption, this is like fluid in the lungs, bronchial constriction, like anytime somebody's doing active work, what does it look like to us when somebody's doing active work? How might we know?
Sensory muscle use.
Accessory muscle use,
Tripod position.
tripod position, very good, yep. Nasal flaring, seesaw breathing, all kinds of ways of telling us like this person is doing more effort than they usually should or have to, right? And that can come with a whole host of conversations regarding that. At some point, not some point, but I think Tuesday, we're gonna be discussing end tidal and how this is our new bread and butter for a lot of things, right? And on the right here, it just looks like little sharks swimming, and that's bronchospasm. What would this sound like if it looked like this? What would your lungs, if I put this on a patient and saw this, what would it sound like?
Longer expiratory phase.
That is a super good answer, but I'm not sure if you know what it means. What lung sound is this? Wheezing, bronchospasm, right? Or also it could be no sound, right? Because wheezing is a constricted bronchiole, whereas no sound may be a fully constricted bronchiole, right? It's the age-old trick question. What happens when you're giving your patient with wheezing albuterol and the wheezing gets louder? They are getting better, right? Because I'm opening closed bronchioles that before were making no noise, and now they're making wheezing noises. I give somebody albuterol and their wheezing gets louder. It might be a sign that it's working. Okay. Make sure you understand fundamentals of innervation here, that it's our brainstem that controls a lot of this, that it's our Medulla for depth, rate, and depth and rhythm, and pons for rate. C3 through C5, the
Keeps the phrenic nerve alive.
phrenic nerve, right, keeps the diaphragm alive essentially. I've got some reference points here. I think I included it on the picture, forgot to remove the text. If everyone took their hand right now, put it on the back of their head, right, and then just slid it down your neck. You feel that big ledge there? That big ledge is the C7.
Yeah.
So when we say C3 through C5, the only reason I say this is, honestly, it's not really even for testing. This is for when you call in your report and you want to sound awesome. Instead of just saying neck pain, you can say approximately around C7, approximately around C5. People lose perspective of where those things are. Primarily the only ones, I had to look T2 up. The only ones I remember is C7 because it's right there, and T10 because belly butt 10. Right, so right here is your T10 thoracic spine. Nipple line is T4, and this, what we call jugular notch, right here at the top of your sternum here, that is T2. Again, you'll see registry questions that'll think that your person took a baseball bat and near the nipple line, and you'll need to answer a question about whether it would be diaphragmatic innervation or thoracic innervation, intercostal and the like. So. A general review of physiology, talking about cellular metabolism and CO2 moving into the blood. If you're not familiar with what a chemoreceptor is, or why do we breathe? Why do we take in a breath?
To release carbon.
Oxygen exchange is
carbon dioxide.
right. There's the big hook, and you need to know that. Before I needed to expose it to you. Now you need to know that you are literally breathing because the pH is lowering because CO2 is rising. Now we're going to talk a lot about this come next Thursday when we spend the whole day going over acid-base balancing. But again, sends a signal to breathe through the brainstem and then down to the diaphragm, and then the pH will balance out, so on and so forth. And we're going to move quickly through some of these terms. I don't want to spend a bunch of time talking about tidal volume. The adult average is around 500 milliliters. We know this already. Yeah. Asterisk. Minute volume, we've heard this before. This is respiratory rate times tidal volume, right? Just remember that tidal volume is your casual breathing. This is us just hanging out right now. I just casually breathe in, that's about 500. I casually breathe out, that's about 500. But it is not the most I can breathe in or out. And that's a different term we'll have to be familiar with. How would I describe dead space? Or describe dead space to me, if you can, without using these words. Coolest game ever? Okay, you win. Air not being used, I'm with you there mostly, right? Like it's air that is essentially not crossing into the bloodstream. That's why we call it dead space. Where is this? When I say, hey, where's the dead space in your body? You would say, my brain. No.
It's like the base of the lungs or something.
What's at the base of the lungs?
Alveolus.
Right? In which case it's largely, your answer could almost not be more wrong.
Right.
Okay, so then if that's the case, then what's the reverse of that?
Now I'm confused.
Sure.
The reverse of what?
So if you're saying it starts in my mouth, right? No gas is exchanging there across the alveolar walls in my mouth. It's just air sitting in my mouth. What about my trachea? Is there perfusion happening there or just active ventilation? So therefore dead space is both my oropharynx, my hypopharynx, my trachea. No gas is going across the walls. It's just going up and down the tube. My bronchioles, is gas being exchanged through the bronchial walls? No, because gas is only being exchanged across the alveolar walls only. As a reminder, the alveoli are not just down here, they're all over my lungs, right? They're a bunch of branching trees with a million different alveoli all over my body. But anyways, dead space is where there is air, but there is not perfusion. And this is going to become very important here. The average amount of dead space for people in their mouths and their trachea and stuff, that's about 150 or give or take a third of their tidal volume. Does anybody know why there's an asterisk here? Whoa, and? I don't think so, you wish. Does anybody know why there's an asterisk here on adult, adult, average, and adult is? The reason is because we teach EMTs essentially that just remember 500 and 150, you'll be good. The problem is here. I've got a obese patient and I have a very thin patient. Which one has a greater lung capacity?
Probably the thinner one.
Okay. What commonly people think is for that person to live, they would obviously have to increase. And the truth is that your lung space does not increase with your size.
Yeah. Because
In fact, it decreases because adipose tissue will push in on it. So what's interesting here is that if we take a patient here and say, oh yeah, big lungs, big person, small person, it's actually the reverse of this. Now this is an extreme example, but what this means is essentially that the closer to what we call ideal body weight you are, the more natural the ratio of your breathing is. Whereas if you've got a bunch of adipose tissue on your thoracic cavity or on your abdomen that's pushing up on the diaphragm or whatever the case is, you actually have less tidal volume. Because here's what we need to, I gotta be honest, I'm always, if you go to registry not knowing anything about tidal volume, ideal body weight and not being able to do the math and just remember 500 and 150, you're probably okay. So if you had to spend a lot of time on something, spend a lot of time on something else and then come back to this. In fact, I'm not gonna spend a lot of time on it right now in lecture because I wanna spend more time on other stuff. But here's the truth of it. If I ask you a question, what is the tidal volume for a patient, you are essentially as AEMTs now expected to know this. Now you won't be bagging patients with this knowledge. This is for setting vents, which is even in an EMT scope, far less likely for them to do. So what this means is for men, we take 50 kilograms plus 2.3 for every inch over 5 feet. So a man who is 5'1", their tidal volume is gonna be 52.3 times 7 milliliters per kilogram. So ordinarily we would just say 500, but truth is that 500 is an asterisk because it's dependent on ideal body weight. Because if you just say 500 for a big person, 500 for a little person, you might be in the wrong whack. And we don't say 7 milliliters per kilogram specifically because a big person that weighs 100 kilograms versus one that weighs 10, that's gonna be grossly different ventilatory expressions, and that's not true. They fall kind of in line. Your body might get bigger, but your lung space slightly decreases. I'm probably only gonna put 1 or 2 questions like this on your tests that say, much like this. What is the minute volume of a 5'8" male with a respiratory rate of 12? Well, 5 foot, so 50 kilograms plus 2.3 times 8 is 16, 20, 18, whatever, right? Times 12, that's his tidal volume. And if we run through the math on it, you'll find that, well, it's suspiciously close to 500. Do we really care about 480 versus 500? No, not really. But when we're dialing up vents, it matters on a long enough timeline, on 6 days in an ICU and so on and so forth. So again, for now, I would say, hey, look, study all the other things I'm talking about, and if you're like, cool, I feel like I've got this, then you should know ideal body weight computation as well as tidal volume and stuff, but it's what I would consider low on my priority. If you go into the next test knowing a lot about knowing nothing about VQ mismatch, but you know that you're gonna nail a tidal volume question, you're gonna get like 1 right, okay? So I do think this is something that you could see, but it should be lower emphasis than the rest. So I'm gonna move past that for now and depend on you to do your own work. Some new concepts for us are things that at least have not been previously mentioned. We talked about minute volume, right? That's tidal volume and respiratory rate. We now are somewhat concerned with what they call alveolar minute volume. And the difference is, what's the difference there outside of dead space? What's the difference in concept between alveolar minute volume and just minute volume? Which gas is actually being exchanged, right? We're starting as AEMTs to say less, it looks like they're breathing or they aren't. And we're starting to say, okay, air is moving, is it perfusing? We're starting to zoom in closer. So naturally, we're gonna have to subtract the dead space or the part that is non-perfusing from the tidal volume to figure out the part that's actually going through our alveoli. So what's the minute volume of a 5'8" male with a respiratory rate? Again, I'm not going to spend a bunch of time doing this, but we'd have to first figure out what his ideal body weight is. Then we'd have to figure out what his tidal volume is, then his minute volume, and then subtracting the dead space to get the alveolar minute volume is how we would do all of that. Again, I am pretty comfortable with you going to registry remembering 500 and 150. If you nail down the other stuff, it might be worth it to know the formulas. I'm not going to stress it too hard. Now, vital capacity, right? What is your maximum inhale and your maximum exhale? That's your vital capacity. If this is your maximum capacity, what do we call your casual capacity, if you will? This is my max in and my max out. But what happens when it's just my casual in?
Is it volume?
Tidal volume. Right?
Tidal volume.
So tidal volume is just how much I'm casually breathing in or out, whereas vital capacity is literally how much you can maximally inhale and maximally exhale. That's your vital capacity. And you know, the way this question will appear on the it's not relevant for us as clinicians, honestly, but how this will appear on the registry will say something about which of the following describes a patient's maximum inhale and their maximum exhale: tidal volume, alveolar capacity, vital capacity, reserve volume, and you'll need to be able to differentiate those things. But it's just a vocab game. Reserve volume is what remains after your vital capacity. There is going to be some air that you couldn't squeeze out of your body, and we call that the reserve volume. Atmospheric air breakdown. You're performing mouth to mouth to somebody. How much oxygen is being delivered? How much am I breathing right now, give or take? How much am I breathing out? Right, because my body uses some of it. So if I'm doing mouth to mouth, are you getting 21% oxygen?
No.
You aren't. We need to know the differentiating factors of external and internal. Of course, external is the external air in the world going into your body across your alveolar wall, whereas internal is not involving the lungs. It's going between your blood, the tissues, and the organs. Which one is more effective at creating energy? Sugar plus O2 or sugar by itself? Sugar plus O2 to the tune of like 40, right? This is a summary of aerobic respiration versus anaerobic. To summarize this, both of these processes are good and natural, right? What can happen is if you're suffocating, your body doesn't instantly die because it can still produce energy without oxygen, but it does so at a cost. Where this happens in, say, day-to-day life is when your physical demand outpaces your inspiration. You run up and down those stairs 100 times, you're not suffocating, but your cells are saying, yo, I need more oxygen. And you say, yeah, but my but my vital capacity is only this much. It's the only amount of air I can do times this many rate. And it says, I need more than that. You say, well, I can't give that to you. So you start to build up lactic acid. So what you need to know as AEMTs is that when a patient isn't getting air, or oxygen specifically, they will enter anaerobic metabolism, and that's not awesome for them. It causes acidosis. We'll get into that more in acid-base balancing. Do we need a quick break? Okay. This is a big fancy word, it's a big fancy chart. I do not need you to know most of this, but I need you to understand the concept, okay? Do you know this? A wet rag holds more water than a dry rag. Do we know this? Oh, there you go. You're welcome. If you want to soak up the most water on the floor, don't use a dry mop. Wet the mop first. The reason is surface tension, right? I don't need you to fully understand that. Suffice it to say, you see how our yellow hemoglobin over here is getting oxygen and it's expanding? That's what happens in our blood. The concept is that if I put an oxygen molecule on a hemoglobin, a heme, it is more likely to attract another. And at 2, it's even more likely, and it becomes exponential. The summary is the more oxygen you have, the more likely you are to get oxygen to bind to your hemoglobin. What that means is the reverse is also true, and this is the most important, or in fact, almost the only point I need you to know, is that the lower your SpO2, the faster it will drop. This is why medics shouldn't be intubating patients in a pulse ox of less than 90.
Say that again?
What I just said?
Yes, please.
Medics should not be intubating patients whose pulse ox is less than 90. You'd be like, wait, isn't intubation to fix the airway problem? But here's what happens, right? I get a patient that's like, and I'm like, ooh, I put him on a pulse ox and it shows 89%, and I'm like, hey, this guy's dipping. Sir, can you hear me? I'm like, whoa, this guy's dipping. Like, I'm gonna intubate this guy. Let's get out the laryngoscope, let's check the battery, let's grab my stuff, boom, the guy's at 89. Do you see how it just plummets around 90? It just boom. If you don't immediately start bagging that patient, they might just go into respiratory arrest. So the idea would be, is their pulse ox is 90, I need to beeline to oxygenation and perhaps ventilation to get their pulse ox up high enough where now I can go through the procedure of intubation. Now, this doesn't count for cardiac arrest or people who are just completely unresponsive. But the point is here is I'm trying to emphasize that the lower your SpO2, the faster it should drop. If I watch a guy go from 99 to 98, I'm like, oh, okay, sure. Long enough timeline, maybe that happens. Now he's at 91 and he drops to 89. We're like, we're at the top of the roller coaster. The lower your SpO2 is, the faster it will drop. If you put a pulse ox on somebody, this is why, all the time first responders will say things like, yeah, dude, he's got a 72 pulse ox. I'm like, how you doing? So he's like, not good. I'm like, probably not. Because at a 72, you are like plummeting your pulse ox. If you get to low enough, if you get to below 90, you are likely minutes, if not moments, away from going to 0. Whereas 95, 94, whatevs. 92, not good. 82, I'm gonna be intubating you soon. I better oxygenate. The second thing we need to know is 8 EMTs, and this is what's called right shift. I don't think remember that. What I need you to remember is that the more acidotic a person is, the less affinity their hemoglobin has. Before, I just wanted you to know, what is a corpse's pH? Well, a corpse's pH is going to be lower than when it was alive. It's going to be in metabolic acidosis and respiratory acidosis. I didn't care that you knew beyond that. Now I super care. If I were to ask you, if I say, hey Trinity, why does it matter to me that my patient's pH is lower? Because even though I'm given 100% O2, his body can only handle 80% because he's acidic, because his hemoglobin will not be able to absorb much because it's acidic. And that's kind of the next step of thinking there. So what I need you to know about this is not all these numbers, right shift, left shift, no. I need you to know that more O2 leads to more O2 binding. Less O2 leads to less. That the lower your SpO2, the faster it will drop.
The lower your pH, the more acidic you are, the less oxygen is going to.
Very good. That's correct. If your patient who's not a corpse is in metabolic acidosis, you should not say, well, I don't understand. I'm giving them all the oxygen they need. Okay, well, that's great. But they might not be able to process the oxygen you're giving them. Very good. What we're going to talk about now is what we call VQ mismatch. Does anybody know what VQ mismatch is yet? That's probably for the best. We already somewhat understand the fundamental principles here. If I've got an empty cylinder, and I've got a cylinder full of air and a cylinder full of water, and I put both of those things into this container, where do they go? How do they separate?
Water on bottom, air on top.
Sure, air on top, water on bottom. What's causing that? It's a force. Gravity, right? Yeah, you're exactly right. If I put water and air into a container, air goes to the top, fluid goes to the bottom. Your lungs work the exact same way. Your lungs have more fluid in the bottom and more air in the top. That makes sense, right? We've never really thought about that, but that's what happens. What that means is, is we have higher perfusion down here where the fluid is, and we have higher ventilation at the top where more air is. You with me so far? This is what we call ventilation perfusion ratio. We've got a very high ventilation perfusion ratio up there because our ventilation is really high, and we have a low ventilation perfusion ratio where there's a lot of blood but not a lot of air. Why? Why is there not a lot of air down here?
Because gravity.
Gravity, baby. Gravity will take it to the top. So we kind of average these things out. You'd say, well, kind of sucks that there's like a bunch of air up there and not a lot of blood. I'm like, yeah, it's not super effective ventilation. You say, well, doesn't it also suck down here where it's a bunch of blood but not a lot of air? I'm like, yeah, it's not awesome either. We kind of average these things out. And this is what we call our ventilation perfusion ratio. Now, you might, by looking at this chart, say, well, it's kind of mismatched, right? Like, there's more ventilation up there, there's less ventilation up there, there's kind of this Goldilocks zone of ventilation right in the center. I'm like, yeah, so having a VQ or ventilation perfusion mismatch is a normal thing. We exist in a state where it's not equal ventilation perfusion all the way through our lungs. It's when it becomes extremely different that we're having what we call VQ mismatch or VQ mismatch problem. So when we look at our ventilation perfusion ratio, what we're talking about is the air, which is represented by V in the VQ mismatch, and we have perfusion represented by Q. Does anybody know why we're representing perfusion as Q? Yeah, P was already taken, right? Because we are getting to a point where we're going to start to concern ourselves, not as clinicians, but as students. We're going to start concerning ourselves with the pressure of gases in our blood, and that's where we use the P, the PaCO2. So now we need a different letter to represent this. I've been telling students for over a decade that the Q is a French word that means perfusion.
Whoops.
It's not. All right. So again, it's not important really that you remember. I don't know why we call this one high and that one low. My guess is because we emphasize the ventilation. I don't really need you to make that distinction as long as you know that there's more air on the top and more fluid on the bottom. Good enough for me, okay? And then for you to also understand that sometimes it's always kind of normal for you to have higher ventilation than there is blood, right? Where in this diagram would the most amount of air exist with the least amount of blood? At the top. What may we call that anatomical structure? That would be so we're talking about the lung? Okay, what about the trachea? How much perfusion is occurring in the trachea? Like 0. Because we call that what? Dead space. We call that dead space because it's pure ventilation, no perfusion. So the absolute highest VQ mismatch that exists in our respiratory drive, in fact, it's infinite because it's 0 perfusion, 100% ventilation is right there in our trachea or in all the areas we list as dead space. The reason I'm emphasizing this VQ mismatch in the term of dead space is because when you have VQ mismatch problems, it's either going to be because of ventilation or perfusion. And we'll get into that in just a second. If we're to look at one of our types of VQ mismatch, this one specifically is dead space. Again, how am I defining dead space? Best game ever? You are correct.
Lots of ventilation.
No perfusion, lots of ventilation. So here we are in a situation where I've got a blocked vessel, which means now, even though dead space is usually relegated to just my trachea, if I've got no blood coming to this alveoli, is this now dead space? Sure.
Yeah.
It's no blood, all air. Can you think of a situation where we might have fine respiratory exchange, but no blood going to this? PE, okay, a clot, okay? If I poke a hole in you and drain out all your lifeblood and you ain't got any anymore, whether or not you were breathing, you got no blood to transport it, so you're having a VQ mismatch, specifically regarding dead space. You're having a perfusion issue in causing that, right? So the alternative, oh no, I have a doubled slide here. Ignore that one. I'll correct it later. The alternative to that is not that I'm having a perfusion problem, but suddenly maybe I'm having a ventilation problem. Whether or not the gas is coming in and out, or whether or not there's not enough space, like through bronchial constriction, or through fluid buildup, or whatever the case is, maybe my blood is flowing just fine, but the air is not coming down. It's still a VQ mismatch in the wrong way. Well, in the other way. They're all wrong, but it's in the other way. Can you think of a situation here where a person might have blood flowing to their lungs just fine, but still have an extreme VQ mismatch? Pneumothorax. Sure, collapse and atelectasis, I'm into it. Anything else? Your patient is in VQ mismatch, and it is not a perfusion issue. What could it be? That is maybe the best answer you could give. It's also very very generic. What's some specific things that, or I can ask it in a way that's easier for you. List me some respiratory problems.
COPD.
Boom, they just start flowing out of you, right? Because what I'm saying here is that a VQ mismatch means that my ventilation and my perfusion are out of whack in an extreme way. Is it a blood issue? Well, no, this guy's got a history of COPD, his pulse ox is 90. My guess is his VQ mismatch is because air is not getting in here. It's not that the blood isn't moving, it's that the air is not. This is a concept we need to know as students, but where it really comes into play, and about the only case, in my opinion, it comes into play, is identifying PEs. Because what will happen is you'll put somebody on capnography, read the results, and say, this dude is moving a ton of air and still dying. I think it's a VQ mismatch based on his end title. So as students, I need you to be able to differentiate. There are two types of VQ extremes. Too much ventilation, not enough ventilation, or not enough perfusion. That's what I need your student brain to do. But as far as clinicians, where it'll happen is you're like, I can't breathe. Listen to lung sounds, clear as a bell. You're like, what the hell? Throw them on end title, you're like, okay, that number doesn't match. Oh, I know why it doesn't match. Because you have a bunch of CO2 building up in your blood and not getting out. VQ mismatch in a PE. Just further expressing this in a different way, because I know it's a lot of different topics. Like Trinity had mentioned before, apex, we expect more ventilation at the top because air is going to rise. At the base, we have more perfusion because the liquid's going to be affected by gravity. VQ mismatch, I do have it listed here as pathological because we're only ever really mentioning, if a doctor says to you, hey, I need you to transport this guy, he's got a pretty heavy VQ mismatch. VQ mismatch is normal, not when we're talking about it. If you're talking about a dude's VQ mismatch, something's in extreme, something's out of whack. And that's either going to be because of shunting or dead space. Dead space meaning the air that is not getting fluid, or a shunt meaning something is preventing blood flow from going there. Lung sound stuff, if you're still struggling with differentiating rails and crackles and the like, you need to tell me, right? I'll build a whole lab around lung sounds or something. But at this point, I am assuming that if I said crackles, rails, rhonchi, not only can you tell me what it is, you can tell me what it sounds like, and you know the meds to give for it, right? And if you don't, we need to do extra work. So I would say again, read the book, look it up. If it's not good, pull up YouTube. They'll have these videos where it sounds and stuff like that. And you do all that, and you still don't got it, talk to a friend. Somebody will say, oh, no, here's where your small issues are. If that's not working, then you can talk to me. And like I said, I'll build labs, or we can hang out on lunch or whatever. But again, this is something that you should have nailed down in EMT so we can build on it in AEMT. Okay? Go through all this stuff. All right. What type of receptor sites does albuterol stimulate? That's very good, right? Beta 2. Is that it? No? Not technically.
No. Right.
So you're right. What you're describing here is you're saying, oh, it is beta 2, which is an adrenergic, right? It's like adrenaline, it's like epi. But the adrenergics are the alpha, beta, B1, B2, A1. It's about the only ones I care about. I only care about 3. Alpha 1, beta 2. Right? So albuterol is an adrenergic, and it primarily agonizes or sympathomimetic. It primarily agonizes beta-2 receptors, meaning I put albuterol into your system, it rolls past your fingers because they don't have the receptors, it rolls past your stomach because they don't have the receptors, and eventually it gets to your lungs where there are those receptors, and it causes broncho what? Dilation. Very good. However, it also has beta-1 effects because albuterol is just a generic adrenergic. It has more beta-2, which is why we don't just give epi. Could we give epi to, let me rephrase, would epi be effective in controlling wheezing? Yeah, it would be. Now it's not in our scope because epi has a metric crap ton of beta-1 and alpha-1, and that's not what we need. We're trying to isolate what we need and minimize what we don't need. In fact, that's why we get the tremors, is because it's a generic adrenergic. So it does a whole lot of this, but it also does a bunch of this too. You can remember this for beta as we have one heart, B1, two lungs, B2. So something that affects beta-1 is going to affect our one heart, right? Something that affects beta-2 is going to affect our two lungs. What is alpha-1 governing? Our vasculature. Your veins and arteries are largely affected by alpha-1 agonism and antagonism. What do we have that causes vasoconstriction? What kind of patient is dying from vasodilation? Anaphylaxis. What do we give patients in anaphylaxis? Why do we give them epi? Because it counteracts vasodilation. So, what medication do we have that causes vasoconstriction? And so now we know that epi is a strong agonist of what receptor? Alpha-1. It also does beta-1 and beta-2, but it does alpha-1, whereas albuterol has very minimal effects on alpha-1. Yeah, baby. Is giving albuterol for wheezing always first-line treatment? Always and never, always, those are dead giveaways that something's wrong with this question, right?
Depends.
Is there ever a situation where you're putting a person on oxygen before albuterol? Yeah, if I got it, ain't nothing wrong with that. If they're apneic, sure, you're ventilating, maybe you won't even be doing albuterol. Yeah, very good answer. Sure. Knowing what we know now, let me ask you this, or what we just recently discussed, whether or not we know it. Could you get wheezing with pulmonary edema? We know bronchoconstriction causes wheezing. Could fluid do that? Yeah? You got a yeah?
Probably. I mean, I guess it depends on what angle you're at.
Yeah. So I told my wife. But if you think about this, if I want you to basically open your mouth as wide as you can right now and whistle. Go. Right? Okay, you can't make much noise there. Part of it's the position of your tongue or the angle, but it's also the size of the lumen, the size of the opening. And in fact, if we're looking at a cross section, right, this would be our alveoli essentially. If this gets constricted, what sound does that make and what do we call it? Oof. Stridor is straight.
Oh, okay, gotcha.
Right, this is alveoli. Stridor,
Yeah, okay.
stridor, yeah. Tony?
Wheezing.
Very good, wheezing. Okay. So let's say no wheezing here, but wheezing here because we have constriction of the bronchiole, right? So what sound would something that is not having bronchial constriction but has mucus causing the same diameter?
Rhonchi.
You could hear rhonchi, but my point is that if this diameter here is the same as this diameter, they're both going to cause wheezing. One is because of the vessel, the vasculature. One is because the space inside is smaller, but it's the same ultimate. If I were to cut these two at this section here and look down at them, They might both look like this, like two eyes, let's say. Okay? Two eyes with tassels, crying out of their pupils. Anyway, the point is that whether or not, so you could see how we might need a medication, even though they have the same diameter and they're both making wheezing, essentially we need a medication that affects the vasculature here, and a medication that affects the mucus and the things on the inside. Giving this person, essentially, that has a mucus or an interior diameter issue, a bunch of vasodilators may have little to no effect, because that's not their problem. Their problem is fluid in it. So, if we kind of back up and I erase my very phallic things, definitely not processing any issues here. I'm just going to cut to the quick. If we give albuterol to wheezing all the time, I'm not saying it's a dangerous intervention, but it might not be what they need. Why might a person have pulmonary edema in the first place? Heart failure, right? What if albuterol is primarily affecting what receptor sites? Beta 2. What does it also affect? Beta 1 specifically. If I give you a medication that increases beta 1 effects, what's happening to your heart rate?
It works harder.
It works harder. Why is that? Why is it now suddenly a bad idea to give albuterol to a person with pulmonary edema?
Because it has to work harder to pump that.
You won't trigger a heart attack because that would be a blockage, but you could be causing a dying heart to work harder.
And it's eventually going to give out faster.
I'm not trying to scare people here, because I would probably, if I was a medical director, be like, dude, if someone says difficulty breathing from albuterol, who cares? But it's not optimal. Increasing the heart rate of somebody that does not need it is a problem. So I would not be giving this patient. It's not my first line treatment to give albuterol. What is my first line medication outside of oxygen? Nitro. Guy says, let's get some albuterol in there. I hear wheezing. And we say, what? No, we need to start with nitro instead. And how we get there is with end-tidal, because end-tidal is a way that you can see bronchoconstriction. Okay? You might hear wheezing but see normal end-tidal, and then you know it's not bronchoconstriction. It's just wheezing because of fluid. Again, it's not dangerous, but it just shouldn't be the first line treatment.
So you're saying you wouldn't, if somebody had pulmonary edema, you wouldn't have the shark fin?
Yes. Well, okay. It is possible that you don't see the shark fin. Because guess what causes a whole bunch of bronchoconstriction? Anything in there, like fluid or inflammation. So there's nothing more divisive in EMS than should you give albuterol in pulmonary edema. Nothing. That is the number one thing where you draw a line through all medics. They all sit on different sides. When I moved to new counties, I call the medical director and I say, what's your opinion of albuterol in the presence of pulmonary edema? And if they say, that's so stupid, you're going to kill them. I'm like, all right, then I won't. But I've worked at places that say, yes, please do that. And I agree with them, so I would do it. So, we'll learn about that stuff. But that's why I say it's suboptimal. Like, you're on a final, your guy's got pulmonary edema, and you give albuterol before you give nitro, you don't fail, but you definitely don't get 100. That guy needs preload reduction, not bronchodilation. Or at least, he needs one more than the other. I'm not gonna spend a lot of time on this. I love this chart. This needs to be your baby. Not so much the CPAP, but differentiating. This is the other thing that kids came back from registry. They said, man, there was a lot of respiratory failure versus distress. What is the earliest sign of respiratory distress? Anxiety, altered mental status, sometimes they call it. What's another very early sign?
Tachycardia.
Very good. Tony, what else?
Increased effort, so like,
I'll take it. The answers I'm looking for more than anything are altered mental status or anxiety. Already forgot. Tachycardia, tachypnea. Right? Those three things. High heart rate, high respiratory rate, anxiety. Those three things. What should you consider as maybe the lowest or last sign you might see of a person? Hypotension. If you are waiting for hypotension before administrating the fluids, you are no son of mine. Right? Disowned. I want your company to call me and say, what are you teaching these kids? They're running me out of house and home with all the saline they're giving. I'm like, they're smarter than you. Shut up. I got a guy the other day, had a heart rate of 106, gave him a bunch of fluid. How'd it turn out? He's okay. Great, we're geniuses. Right? Tachycardia. Oh my God, got so much fun. The big thing is for CPAP. We know CPAP, right? We're aggressive in learning it in EMT. We know that we want to be aggressive in its application. Make sure that you are familiar with when you can't give it. That's why I made a little intervention card, right? The reasons you want to give it and the reasons you can't give it. The only reason, or the only part that this kind of changes with right now is the fact that we're doing this for patients with pulmonary edema or for COPD exacerbation. That's one of the major confusions. People are like, I don't hear any fluid, I'm not doing CPAP. Do we share that? Is that news, or are we like a big like, no, even COPD, even asthma, all these things get CPAP? Do we all know that? CPAP is for people who are hypoventilatory, not just for pulmonary edema. That's a major misconception. We're helping, it's almost like splinting their airway. Whereas this changes now, we say, I think this guy needs CPAP, what's his blood pressure? Because I'm gonna pop in a nitro before I throw the CPAP on. That's kind of the real change here. I'm not sure how familiar we are with this bit here. Do we know about attaching albuterol Atrovent to CPAP? And do we know that you traditionally add about 7 extra liters of air? Is this news to us?
A little bit.
I took a picture of this. I literally just pulled it out of the packaging. What I'm saying here is that we have taught you 5 to 10 centimeters of water is what you set it at, right? Set it at 5, how are they doing? They feel a little better, goose it up, 8, 9, 10. They feel okay, oh, it's a little, getting tired, okay, turn it back down to 5. And mostly, your air matches the PEEP. I twist the little knob to get to 5, and then I turn the air to 5, and it lines up. And that kind of continues steadily up, where most EMTs, they don't actually know the chart. They just say, well, if I put them at 10, I'm gonna put them at 10:02. And that's not crazy. It's not exactly right. As you can see, 10 should be more like 8 oxygen, 10 PEEP, but I'm okay. If an adjunct came to me and said, what do you want me to do on this final? You know, Amanda put them on 10 PEEP and also 10:02, and I'm like, whatever. So that's not crazy. That changes if you suddenly attach a nebulizer. You need more oxygen, and usually to the tune of about 7 liters per minute. I point this out more as clinicians and less as I think that I'm going to ask a test question. Just know that if you're trying to get some infusion of, or small volume of nebulizers, you're going to need more O2. Talk about contraindications. If these are news to you, make sure you study them. Chest rise and fall is a huge one. Kind of got to zip through some of this stuff. Have we talked about Barney bad, Big Bird good? No? Okay. What we're discussing here is colorimetric devices. Everyone hates Barney, everyone loves Big Bird. And this is true across all cultures and all people, right? It's getting a little dated because I don't know how many people remember Barney anymore. I don't care, I'm still using it. What this means is when a patient is intubated or on an advanced airway at all, like an iGel, you hate Barney, right?
Yeah.
All right, see?
Wait,
Lucy?
you know that song?
No, I don't know the song. Is
What is it?
there a dance?
There's a song that's like, Kill Barney or something.
I love it. The point here is that Barney is bad and Big Bird is good. What this means is if you've put an iGel or an extraglottic airway or even an ET tube, there's a way of checking, is it in the lungs? And how we do that is by attaching a colorimetric device. If it turns purple, essentially, that means this litmus tab is not detecting CO2. If it turns, it stays purple, but if it turns yellow, then great, CO2 is passing by this and your tube is good. I don't know that you'll really use this in the field. I certainly never have, but I have seen it in various forms at companies and different questions. The point here is you need to check whether or not your airway device is effective, and one of those ways is through colorimetric. Another way, I don't know the name of this thing. I call it a dead space bulb. What this means is is that your stomach, ideally, has very little air in it. And so if I squeeze this ball and I attach it to the top of the eye gel and let go, it should stay squeezed. If it inflates, well, that's because air's rushing into it, which means it's in your lungs, which is what I want. Again, I've never used one of these in the field, but that's what that is. The reason I don't use these in the field is because I put them unentitled, because I'm not an idiot. And that's really what we're doing here, is, again, this is our new bread and butter. You walk over, and nobody seen it, has anybody seen an eye gel done? Dude, it's like the easiest thing in the world. You reach in, grab the tongue, bop, jam it in there. Watch, I'll show you. Hold on. Right? I mean, you are my only target now.
My mom's friend is a NICU nurse. I got to see the pink one.
Sure.
It's
Oh,
really
yeah.
sad.
It's like this.
It seriously is like a big.
Yeah, dude.
It's tiny.
It is so, it's largely foolproof, specifically in eye gel. And so what you do is you're just like, I got an OPA and I'm bagging, everything's kind of sewed down. I say, Courtney, throw me an eye gel, we're gonna size it up on this guy, great. I pull out the OPA, I jam it in the eye gel, I go back to bagging. And I say, hey, when you get a second, grab me an end title. And I hook that end title on so now I can chart it. It comes back as 0, what does that mean?
Bad.
It means no gas is exchanging, your tube is bad. I tell you about the time I had to debate firemen on scene with a cardiac arrest? I had a 6-week-old. It was one of the last calls I ran for. I came off the truck. Guy's like, we got this baby intubated, 6-week-old. And I was like, damn, I can't believe you even tried, let alone were successful. That's like unheard of. I put it on the end title, comes back 0. I say, hey brother, your tube's bad. He said, it's not bad. I said, if you can explain to me why a good tube is registering as a 0, we'll leave it. He said, I can't. And I said, so? He said, so I guess we have to pull it? I said, yeah, dude. We pulled it, start bagging them, end title goes up to 35, 40. I'm like, what are we doing here? Pride was getting in the way of this 6-week-old's life, dude. Holy crap. Lastly, we want to talk about these things. I'm not going to spend a lot of time. I think we have a decent grasp of this, right? This is something I came up with. Use whatever works for you. I use lost breath because I saw a lot of students bagging patients while seated. One of the first steps should be is to lay a person who is not breathing down. It's the only way we can get an effective seal. I watched the medic students time and time again, right? You were there, time and time again, watch them try to bag somebody. And the adjutant would tell them, it's not working out, it's too difficult, it's too easy, it's not working out. And they're like, okay, I'll keep doing it. Here's a good way of doing that, the steps that we need to take to go through it. Sexy bagging. Mr. Witcher likes this one a lot, the sexy bagging. This is not an order of events. This is just a list of things to remember.
It's her favorite.
Nice. Big fan of bags?
Yeah.
I get it.
That one.
Right? So we want to make sure to elevate the head. Sniffing position is not our priority, right? Mostly we want to do the jaw thrust or the head tilt and get them, but we do want to end in a sniffing position, right? Sooner than later, use your boot if you must. Use a blanket to get them up. Extra equipment meaning OPA, EGDs, or end title, and of course suction if we need it. This is about the last thing. This is our discussion we're going to end on here, I think, largely talking about extraglottic devices. Before, as EMTs, we did not have access to advanced airway devices. Okay, and now we do. And so that means eye gels are an advanced airway, Cobras, combi tubes, King, all these extraglottic or supraglottic airways are advanced airways. They're also called blind insertion devices because much as we would use a laryngoscope to look in there and then trace an ET tube through their vocal cords as paramedics, these are blind insertion. Open that mouth, jam it in, right? Jam is probably the wrong word. Place it. EGD versus SGA, you'll hear these terms used interchangeably a lot. Extraglottic device or supraglottic device is probably more important. You know, extraglottic device is the largest umbrella and supraglottics are part of those. I don't super care about the differentiation. I can't stop myself from making it though. What this means is that there are some things that sit on top of the epiglottis and some things that go into the esophagus. And that's the difference between supra and extra, but no one cares about that. The indications, what I want you to think of first, even before breathing, is my patient responsive to pain? And if they're not responsive to pain, I'm putting in an eye gel. Why do I want that?
They'll get her to like,
Okay, I like that. But what if you said, you know, you're working with this salty old medic, and you say, hey, this dude's not responsive to pain, dude. I'm gonna try an eye gel here. And he says, he's breathing though. Why would you do that? What if he stops is a good answer, but what am I trying to prevent? Aspiration. If you're unresponsive, if you're not responsive to pain, you likely don't have control over your own airway. So even though the guy's breathing, I always say this when medics will call me up or EMTs will call me up and they say, should I have done a tube? Should I have done an advanced airway? My response is always, would they accept it? And they're like, well, I mean, they would have. And I'm like, then you should have. Now, you can test this by jamming your finger down a person's throat and seeing if they gag. I do not recommend that. They might bite off one of your fingers. How I test this is with an OPA. I see a guy unresponsive on the ground, and I'm just like, they'll teach you things, cup test, eyelash test. None of that's ever been effective for me. So what I would do is I'd just be like, hey, toss me an OPA. Jam it in there. Guy's like, oh, I'm like, okay, never mind.
He's like, my bad.
Right? But if I put it in and he can take it, even if he's breathing, like, give me an eye gel. Because if he throws up, it's going to go up, in, and then into his lungs. So I want your primary motivator to be indication for extraglottic device to be their level of consciousness, or rather their responses to pain. Are they unresponsive or not? The breathing comes in a close second. Now there are some situations this isn't appropriate. Like mom's like, yeah, I saw my son do a bunch of heroin and now he's on the ground, and you're like, cool, I'm gonna put in an eye gel. It's like, hey dum-dum, as soon as you give that Narcan, he's gonna hork that up. So there are some cases where this isn't exactly true. But in the cases of like cardiac arrest and other unresponsive patients, again, don't lose sight of the fact that we're trying to prevent an airway issue here. And that it's also good if they stop breathing, we already got one in where we need it. If they start to choke on it, just pull it out. Simple, right? True in love, true in life. So we've got, I don't teach the sizing of this stuff. Most of it is listed right there on the device itself. As a reminder here, if you can put in an OPA successfully, then they should have an extraglottic device in them. Asterisks, except for when you're about to give an immediate reversal agent like Narcan. You can, it's not crazy. I'm proud of you for being like, dude, this guy's not unresponsive, blam. It's like, okay, well, you're gonna be pulling that out in like 30 seconds after Narcan, but good job. It's for unresponsive and apneic patients for sure, cardiac arrest for sure, and for people who are hypoventilatory without a gag reflex. Not just people without a gag reflex necessarily, but oftentimes. What was I gonna say? Oh, where this fits in for my analytical brains, where this fits in on your patient assessment is essentially after BVM and OPA. If you identify your patient as apneic and hypoventilatory, it's a situation of if I've got an eye gel and an OPA sitting next to me, I'm just gonna jam in the eye gel. You usually won't though, which is why I'm certainly okay with you saying, hey, give me an OPA in a bag, I'm gonna bag this guy. Is this effective? Yeah, it's good chest rise and fall. And now you're just kind of on a timer to be like, okay, well, I'm gonna check to make sure they, I guess what I'm trying to say is don't put in an eye gel before you check a pulse. You need to make sure that CPR isn't the priority. But then as far as I'm concerned after that, put in an eye gel as soon as you can. I'm
So
okay with that.
during the BVM,
You go through ABCs
So you
and
want us
then
to
into
do-
CABs.
you want us to start with the OPA and the, okay, no gag reflex, and then
So-
do one, and then say, alright, I'm gonna put in the eye gel now.
There is nothing wrong, I think, with you saying, my patient is unresponsive, I'm gonna start with an eye gel. Unless it was much easier and faster to get to an OPA, right? If I'm like, hey, my guy's not breathing and his pulse is low, I'm gonna start bagging him. It is okay to say, just grab me an eye gel. And so I'm bagging this guy, you give me an eye gel, I throw it in, never did an okay, I'm okay with that, for sure. But if you arrive on scene and they have an OPA in, you should be thinking, oh, this dude takes an OPA? Hey, why don't you get an eye gel out while I'm getting a report, right? In fact, even Denner teaches like a genius for his medics to like, in cardiac arrest, not even to innovate, to just beeline to eye gels. Highest success rate. There's graphs out there that show cerebral perfusion, how well these airway devices are improving the oxygenation of our brains. You know, it's at the top. BVM and OPA does the best. You know, the problem that I have with that is it's a really difficult skill. Any monkey can put in an eye gel and then bag that, so I do that. It takes an awfully practiced person to innovation, and it's one of the lowest success rates and one of the lowest perfusion rates. So you might say, oh man, I wish I could innovate. Like, we teach the medics not to innovate in many cases, for crying out loud. What are you doing? Throwing an eye gel, bloop. And now attach entitle to it.
Yeah.
Now, there's all kinds of different extraglottic devices. Our preference is that you use iGel. It has the highest success, it's the easiest to do. But there's all kinds of other things like King LT, CombiTube, LMA, Cobra. These are all listed in your book, and you should at least read through them. There's some good information there about the differences. When you go to registry, I do not know which one will be available to you. This one doesn't require much. You lube up the tip, jam it in the hole, right? iGel success. Woo. Depth is important, they have ratings here, but something like a King LT, you'll place in, and then you need a 50 milliliter syringe to fill up the air. What's happening here is that you're going, I think I have pictures for it. Oh yeah, use lubrication, bring it from home if you must. Okay, so here for example is what's happening with an iGel. You're putting it in here and it's essentially occluding the esophagus and forcing all air administered through that end of that tube to go into the trachea. It sits right on top of it, okay? Now, they'll tell you, oh, it's got a little channel here for suctioning with a 14 French soft suction. I don't know what yet my message is to you. If I get a patient that's like, I'm probably pulling this out and suctioning whatever comes, right? If I get a guy where I'm like bagging them, medic's working or whatever, and they start, I'm like, okay, I'm pulling out that iGel and I'm turning their head, because what I don't want to happen is a huge volume of emesis to build up here and then collapse trachea, collapse carotid arteries, flow into it. So I'm like, okay, this sucks. I'm just gonna pull this out, tilt their head so they vomit all over my partner, and then I'll suction whatever's left, put the iGel back in. Quick lube it up, throw it back, right? So that's my message to you. My message to you is not to utilize the channel and be like, oh, they're throwing up. I'm just gonna trace in the tiniest straw in the entire world and then suction that up. Nah, just pull the whole thing, drain it. But iGel is our preference. When you look at things that are supraglottic devices, like this right here being a combi, no, this is a King LT, I suppose. These are designed for failure, right? An ET tube, a medic is going to pull up your epiglottis, pull up your, stick it right here in the vallecula and pull this whole thing up so he can see your vocal cords and then trace a tube right into your lungs and then fill the air so no air gets out or in or anything else. Are these devices, not the iGel that sits directly on top of this, but supraglottic devices like the King and CombiTube, they are designed to go in the wrong place. They are designed to go in the esophagus, and then you fill the balloon up with air, or the two balloons if it's a CombiTube, and then there's a little hole right here. This is why I can't go down or up, the air must go now down in the trachea. That's why they're blind insertion. Now, some of these, much like if we'll see in the CombiTube, the reason why it has what we call a dual lumen, and I have seen this terminology on the registry before, these are single lumen, they just have one hole. This one is dual lumen because if you put it in the esophagus, essentially, you see how it's got these two tubes, two inflation cuffs, and then the two tubes at the end? What happens with the CombiTube is you push it into your patient, you puff up both of the bulbs, and then you try the first one. And if their chest rises and falls, you're okay with it. But if their abdomen rises and falls, that means that you're on the tube that's in the esophagus, so you switch tubes to the one that's pushing to the trachea. Now, that's a lot of work, and it involves some thought process. This one requires neither. That's why we prioritize it. Yeah?
I mean, in what situation would you want a CombiTube?
You wouldn't.
Like what?
Why does it exist?
Yeah.
Part of it is just years of development. No, you probably will not be surprised to hear that they came out with a CombiTube before they came out with iGel. So part of it is advances. Part of it also is just, you get some 70-year-old doctor who's your medical control, and he's like, we've always used CombiTubes, and CombiTubes work, and so he's like, we're gonna keep using that. He's not crazy, but it is suboptimal, no doubt. All statistics show that not only does this involve less cerebral perfusion, it's obviously more work, and it causes a ton of trauma. Putting a combi tube in usually is a pretty raucous experience, whereas just setting something on top is so gentle. I come in all the time, I get a patient, you know, an EMT is put in a combi tube. This used to happen somewhat frequently. They put in a combi tube and they're like, combi tube's good. Well, you gonna be one of those medics that just pulls it? I'm like, no, I would pull it, or I would leave it if the end tidal was fine. The end tidal's crap. This guy's got blood everywhere because that guy probably didn't just gently push in. He's probably ramming it in and tearing up the trachea. It happened all the time. And so I'm like, no, I'm not one of those arrogant medics that pulls an advanced airway to intubate. But his end tidal is low, so you're just bagging the wall right now. This means nothing. And look, it's full of blood. This guy had a heart attack. Now he's suddenly full of blood. That's on you, dude. What the hell? You know. So, to answer your question, dude, different strokes, man. Some people just use different devices. I used this at the start of my career. Then they came out with this. And then they came out with this, and I moved. You know, the companies I worked at used them. But what I don't know is which one's going to be at registry, which is why I expose you to all of them. Wouldn't it be a shame if you didn't know anything about combi tube and walked in and saw two dangly bits and were like, uh-oh, I don't know how to do this station. Again, we cap it with end tidal. It's our golden, not ratio, it's our hallmark for whether or not this person is perfusing. In fact, when we talk about cardiac, we'll start to say, like, what do we use? One of the most effective ways to determine if our ventilations are working is what? Chest rise and fall, right? Okay, now end tidal is that. I can look, chest rise and fall is very good, but end tidal is what I'm looking for. If end tidal comes back as 0, you are not exchanging gas. And we will come to learn in cardiac arrest that if I see a guy and he's ticking along at 12 because he's dead as a doornail, and suddenly it goes from 12 to 20, you better check a pulse. The only way that end tidal is jumping up like that is if he starts breathing on his own again.
Yeah.
And so now as a metric in cardiac arrest, we are looking for, and I'll have a test question and probably a final question that says, what is the number one indicator that a patient has not sustained, but that ROSC has occurred, and it will be a sudden increase in end tidal. 100%. Contraindications for extraglottic devices. Don't think too hard about this. Hopefully these are obvious. I don't want to put, or I shouldn't rather, put an extraglottic device in Tony right now. Why? He's got gag reflex, presumably. It's going to be a very uncomfortable experience for him, right? Another thing is esophageal disease and deterioration. If a guy has esophageal varices, like this guy calls because he's been horking up blood, now he's unresponsive and stuff, be careful, this dude's got paper esophagus. You put something in there, it might tear a hole in it. Caustic substance, this patient was suicidal, they took a bunch of bleach, they drank it to the point of unconsciousness. Let's maybe stay with an OPA. What we don't want is gasoline and acid and stuff corroding that esophagus or trachea, and then we jam a big hole in it with our supraglottic device. So they aren't wholly innocuous. There are some times, we got test questions coming on that too, where you're like, oh, boom, I know, this is an obvious EGD, and it's like, dude, he's got esophageal varices. That's not good. What if you nick one of those, now he bleeds to death in his own airway? Okay, last bit, I think. Oh, we did okay. We did okay. You've established an I-gel in a pediatric patient in cardiac arrest. What is your compression rate? Ratio is the question I'm trying to ask. What is your compression ratio?
3 to 1.
3 to 1? But we don't know the age, right?
This is pediatric, be
Oh,
17 or
pediatric,
pediatric.
Could be 17 pediatric, sure. Sure.
Oh,
What if it was an ET tube? Do you know what your compression ratio would be then? Let me ask you this. It's an OPA. What is your compression ratio for an adult?
32.
30 to 2. Now you put an I-gel in that guy. What is your compression ratio?
32.
Continuous.
Oh.
If you have a supraglottic or an ET tube, you do not interrupt. There's no reason to. You have a secured airway.
So you need CPR and that's
And they're just bagging along. I will say that every time they compress the chest, it gets real difficult to bag, so you have to do what they call asynchronous bagging. So they're like, boom, like this, and you're not really thinking about it too hard. You're just kind of, here's what's funny. Now that you guys have end tidal, like, you aren't even gonna count ventilations anymore. and win cardiac arrest. There's no point. It doesn't matter, right? Like, you have a different respiratory rate, you have a different respiratory rate, you have different body sizes, different knees, different lung capacities, different da-da-da. I don't give a shit about any of that stuff. I'm watching end tidal. 35 starts to go to 34, oops, slow down your bagging. Bam, goes up to 35, 40, great. Starts going up too high, 45, oh, I need to speed up my bagging. And you will stop counting respirations because you're just watching end tidal and keeping it between these two bars. They're like all the time. I had to learn it. For a medic, I never even counted respirations. I had to learn it here to teach you guys about what the ratios were like. I'm like, why the hell would I care? I'm just watching end tidal, we don't have that. Right.
It's like not there yet.
Yeah, and where I noticed that was when I was helping the medic class, they kept getting in front of the monitor that wasn't even real. I was like, hey, move, dum-dum, how am I, oh wait, that doesn't work, and because I'm just so used to just watching, you know, it happens all the time. I'll be doing a cardiac arrest or whatever, see their end tidal is 25, I say, hey brother, hey, you know, fire's bagging or whatever, so slow down for just a second, just ease up on it, you know, and it's like 25, 27, 28, you say, okay, you're just going a little too fast, just keep it at that rate. He's like, well, what number? I'm like, what's the count? What's that? I said, no, you just watch that number. It starts going too low, you slow down. It starts going too high, you speed up. I want more or less out. Tony?
The end tidal is so important. Why don't we have it in our scope for EMT?
Time. If you look at the national scope, because I asked that same question, I was like, it's so harmless and so good. The problem is that applying it is easy. Anyone can apply it. Interpreting it is a whole different animal. It's why we have an entire lecture on end tidal. So when the national scope came out, you know, that one I referenced that showed the difference between EMT, AEMT, at the top there it says, look, we strongly considered putting end tidal in the EMT scope. But they already are like, on average, 6-week courses. It was just too much to add. Not because they're not capable, but just too much. So that's the answer to your question. It's just already full there. So they decided to save it for AEMT. One of the last bits I want to talk about, this is our new baby. You remember me talking about the dope mnemonic? This is now something we need to familiarize ourselves with. What this means is I put a patient on a pulse ox, let's say. I put him on a pulse ox and it reads 0. Right? Let's say I put it on Destiny. Right now I put a pulse ox on Destiny and it reads 0. What do you do? CPR? Bagging? iGel? None of that stuff. Why? Because she's obviously alive. What do you do first? Maybe check your equipment, right? So the same thing we want you to think about here is when I come in, hey, we got a cardiac arrest here on bagging. I say, great, I got an iGel already. I'm going to throw that in and put end tidal on. End tidal comes back as 0. My first thought is not, well, I guess they're just super dead. My first thought is maybe there's something wrong with the equipment. First, I grab the cord, I trace it back to the monitor. Oops, it's not plugged in. Let me plug it in. Still 0. Okay, is it possible that my tube is dislodged? Did it go in the wrong place? Is it down too far? If I take a King airway, a King LT airway, which is designed to go into the epiglottis, right? If I push it down too far, where is it likely ending? I push the King LT too far down, and it's not in the esophagus. Where has it ended up? I throw a peanut in your mouth, and you start choking on it because it's occluding your airway. Where is it likely to have ended up? Certainly in the most narrow portion, right? Well, where it's causing an issue, what I'm trying to get here is do not forget that the right bronchi is the widest and shortest, which means, and a question coming is, you know, I push in a King LT and my pulse ox is low, my capnography is all wrong. One of the answers is probably just to check that you need to pull back on it. You might have pushed it down into one of the lungs. So you need to probably not necessarily pull it out, just pull it back. It's just down too far. It went right into the trachea, which is awesome actually, but not if it's only in half of the lungs. You need to back it up, right? And so the point here is this dope mnemonic shouldn't be like, okay, I got an iGel and I'm bagging, and then I'm gonna say this, we're gonna have to push for this year, kids. We're gonna have to say, I'm gonna start bagging my patient, now you say that. I'm gonna start bagging my patient, okay? What I want you to immediately follow that up with is, how does it feel? Or is it working? Is it effective? You need some kind of play here with the adjuncts. Time and time again, I saw students say essentially, I'm gonna start bagging them. Anyways, and it's like, no, like, okay, we saw the nail, we hit it with a hammer, great job. Now like walk around the nail or ask how the nail's feeling, or like, we have to investigate, okay, I hit it with a hammer, did it work? We said, no, the nail's still there. All right, hit it again, right? And that's where this comes into play. All right, I'm gonna put in an iGel, I'm gonna start bagging. How is it? How's my end tidal? How does it feel? They say, oh, I'm glad you asked. It's very difficult to bag. Doped mnemonic. All right, is my tube in the wrong place? Is it too far? Is it not far enough? Is it dislodged somehow? Is it obstructed? Did they vomit and it backed up into the tube, right? So we want to check the equipment first. Do I have a pneumothorax, which is not a failure of the equipment, but a failure of the thoracic cavity? Am I pushing against a collapsed pneumothorax? And like I said, so this is all just this kind of stuff, specifically equipment failure, meaning things outside of the tube. Like maybe it's just my end title, maybe the battery on the monitor is dead, maybe something other than the tube itself. So this needs to become part of our nomenclature, and we're gonna trickle it into labs. We're gonna say, you're gonna say, I don't understand, I'm bagging this guy, got an eye gel in, I got him on oxygen, but his end title is still low. And you will need to say, wait a sec, it's because I'll tell the adjuncts, let's say it filled with emesis. And if they don't know this, then they make them do 10 minutes of CPR. You know what I'm saying? Cool. All right, that's it.